Ladies and gentlemen, welcome. A very good afternoon to all of you, and I hope all of you had a good lunch, especially for those of us who have worked early in the morning. And Dr. James, once again, I'm your chairperson for today. Welcome to the College of Family Physicians Mandatory Medical Ethics CME webinar on Informed Consent and the Civil Law Act. As all of us know, all SMC registered doctors will be required to acquire 5 MME CME core points before we can renew our practicing certificates from 2026 onwards. And with this in mind, the college is very excited today to collaborate with the Medical Protection Society to collaborate and to deliver this webinar. We have an exciting program lined up for today, and I believe all of us will be to learn from MPS expertise in this area of medical professionalism, ethics, and law. Now, before we start, I'd like to bring to your attention some house rules today to ensure a smooth and enjoyable experience. First, just a reminder that you will need to attend the full 2 hours webinar to earn the 2 MME points. I think there was a question. You do not need to put in your MCR number and your name because you have already registered. We just need to log on and to be present. And secondly, we won't be using the raise hands function for today, but we'll be using the Q&A function for you to post your questions and responses. And aside from the case discussion, we will address your questions at the end of the Q&A section. We will try to address as many questions as possible. And if we are unable to, we will review them after the session and to send the response to you subsequently. And lastly, we hope that you can complete the feedback form at the end of the webinar so that we can understand what went well for you and areas of improvement. All right. So without further ado, I would like to start this webinar off by inviting Dr. Suraj, Vice President of the 29th Council, to say a few words. Dr. Suraj, please.
Thank you, James. Good afternoon, everyone. I will just say, take a minute to say a few words. Thank you all for attending this afternoon's webinar on one of the MME topics. I know it's very well attended today this afternoon. Just reflects that everybody wants their CME points or their MME points. I wanted to assure our members and participants that the college is committed to organize MME activities over the next 2 years or the 2-year cycle. And there will be adequate opportunities for everyone to acquire the 5 points. The same goes for the other professional bodies, the Singapore Medical Association and the Academy of Medicine. All the 3 professional bodies will be delivering MME activities over the next 2 years. And we all agreed that for the first 2-year cycle, we will cover the basic topics in medical ethics and law, and as well as professionalism. And today's topic, informed consent, it is an important one. And it might already have been covered by other professional bodies, but it is an important topic that can be discussed again and again. And I'm happy that today we are collaborating with the Medical Protection Society. And I think we've got a very good program lined up this afternoon. So without much further ado, I'm going to hand you back over to James so that we can have an enjoyable afternoon of learning. Thank you.
Hey, thanks, Dr. Suraj. So we'll now move on to the webinar per se. So first of all, I'd like to have Dr. Robert to start off by giving us an introduction. Dr. Robert Henry, he's the Medical Director at Medical Protection Society. He studied medicine at Dundee University, graduating in 1981. He was a partner in the urban teaching practice in Dundee for 12 years, and he completed a master's in philosophy in law ethics in the medicine at Glasgow University in 1992. And that led him to consultancy work for MPS and part-time teaching at the university. He established the MPS Scottish office in 2009, and in 2011 he was appointed Deputy Medical Director, and in 2013 he was the Medical Director of MPS, responsible for medical legal services delivered to members worldwide. So, Dr. Robert, over to you.
Thank you, James. And good afternoon, everyone. And it's a really great pleasure for me and my colleagues at MPS to be able to be presenting this webinar in partnership with the college. I think the introduction of the mandatory medical ethics CME in Singapore is a really important step forward and gives all doctors in the country a good opportunity to reflect on their practice and to take time to think about the basis on how you interact with your patients. Today's subject is consent, and we're going to be looking at the principles of consent and shared decision-making, and then going on to consider some of the changes in the law in Singapore as it relates to consent and giving of medical advice in light of the Civil Law Amendment Act 2020. And we'll be joined for that section by one of our very respected solicitors from one of our panel firms. After a short break, we're going to have some case studies, and I really would urge you to think about the cases and put your questions to us so we can perhaps pick up some of the real-life issues that family doctors working in Singapore are having to confront. Consent is a fundamental legal and ethical principle, and all patients have the right to be involved in decisions about their treatment and care, and to be able to make informed decisions if they can. The exchange of information between doctor and patient is essential to good decision-making, and we at MPS see some of the serious harm and some of the disputes that can result if patients are not listened to or not given the information they need, as well as the time and support to understand their situation so they can make properly informed decisions about their care. One of the things I think with the MME coming in, it underscores the fact that doctors must be satisfied that they have their patient's consent or valid authority to provide care. And the purpose of this webinar, as I say, is to make sure you have an opportunity to have the skills and knowledge to meet this standard, and also to be able to reflect on the ethical principles that underpin good practice. Obviously, all doctors are expected to keep up to date with the law and the current guidance by the Medical Council and other regulations relevant to your work. And it's with this in mind that we at MPS are committed to supporting our members and keeping up to date with such developments, which again is, I'd like to say again, how pleased we are to be able to be collaborating with the College of Family Physicians here. I'm also pleased to announce that MPS will be offering a 20% discount for new joiners. So if you are new or thinking about joining MPS, please scan the QR code, which came up at the start but will be repeated later. And you can always get in touch with our Singapore representative, Julia. And again, her details will be here later. So thanks again to the college for working with us on this. And I'd like to pass back to Dr. James to move on to the meat of the webinar. Thank you, James. I think you might be on mute, James.
Sorry about that. Hey, thanks, Robert. Apologies. Yeah, so thanks for starting us off. So I have here the program with us today. We have a packed program. I hope it's exciting. We're going to have the first two parts where Dr. James Thorpe and Mr. Legg will bring us through two topics, and then we'll have a 5-minute break, and then we'll come in back for the case discussion. For those of you who are keen to explore the MPS membership, I think at the end we'll flash that back again, so not to be too worried. Okay, so without further ado, let me just move on to the next segment. So now we're going to have Dr. James Thorpe, Deputy Medical Director and Medical Legal Consultant of MPS, to give us the first talk for today. So James has provided expert medical legal advice to MPS members since 2014. He has a master's in law in the medical ethics and law, and has an interest in medical education, working with MPS risk prevention team to reduce medical legal risks and improve patient safety. And before joining MPS, James trained in general and vascular surgery, and is a fellow of the Royal College of Surgeons of Edinburgh. So, Dr. James, over to you.
Thank you, James. Thank you. I'll just share my slides and get started, but it's an absolute pleasure to be here with you all this afternoon. Okay, so hopefully you can all see my slides. So, as I say, my name is Dr. James Thorpe. I'm Deputy Medical Director here at Medical Protection. Pleasure to join you this afternoon. Prior to joining MPS, as James mentioned, I worked as a general and vascular surgeon. I'm only too aware of some of the challenges that you all face with respect to consent and shared decision making. Now, arriving at decisions with patients about their healthcare is a core component of our work as clinicians. This is true across many aspects of work, from the decision to start a new medication in primary care to suggesting a screening test or planning a procedure. And as I'm sure you're all also only too aware, medicine has become significantly more sophisticated over the last few decades, with an increasing number of treatment options available for patients. And this has increased the complexity of decision making, both for us and for our patients. Parallel to this, I'm sure you will have noticed that patients' expectations have changed with respect to the amount of information they want to receive. They want their opinions to be considered, and they want a greater involvement in decision making. So because of these factors, clinicians and patients have recognized the need for a model of decision making that is inclusive of patients' preferences and values, while still respectful of the skills and expertise of the clinician. So this webinar presentation will address a model of decision-making called shared decision-making that fulfills these criteria, as well as offering the potential to effectively lower your medical legal risk. The webinar is designed to help provide you with the skills and tools for effective decision-making with your patients. So the presentation today will focus on 4 main areas. Firstly, I'll have a look at the risks associated with clinical decision making. Secondly, we'll have a look at how effective healthcare decisions are made and the important factors that influence this process. Thirdly, I'll examine a variety of ways, including the use of decision aids to effectively communicate risk to patients. And finally, I'll present our medical protection 6D framework and show how this model can help you reach shared decisions with patients. So let's start off thinking about where the medical legal risk in clinical decision making comes from. So really, there are a number of factors that affect the clinical decision-making process. For example, there can be patient factors that affect the decisions. For example, the patient's perception of the risk of a particular procedure or the risk of a particular medication. Sometimes their emotional state, how they're feeling, might affect their decision-making. So if they're particularly upset or stressed, that can influence how they make decisions. Other patient factors could be external pressures from relatives or cultural issues which might affect their decision making. So we have to bear all of these things in mind. Moving on, of course, there are also clinical factors which are going to affect the decision making process. What's the clinical context? For example, consenting a patient, going back to my clinical practice, consenting a patient for repair of a ruptured abdominal aortic aneurysm is completely different to consenting someone for an elective cosmetic procedure, for example. There are doctor factors that can affect the clinical decision-making process. Doctors obviously have different levels of knowledge, skills, and experience in particular clinical areas. Family physicians are obviously well used to prescribing a variety of medication, for example, whereas a doctor working in surgery is clearly going to have a different skill set. Things like being hungry, angry, late, or tired. You might have heard of the so-called Holt syndrome, but doctors are quite frequently hungry, angry, late, or tired due to the pressures of their work. But these things can affect our decision-making process. And of course, there are system factors that can affect the clinical decision-making process. So you might be under time pressure. there might be an urgency to make a clinical decision. You might need to consider availability of resources, and there might be difficult to provide some treatment options due to lack of resources. So clearly, decision-making is complex, and I'm sure that this doesn't come as a surprise to you all as busy working professionals. And it's interesting to note that research has consistently identified that patients want to be more involved in decision-making and are often disappointed in their experience. And what we know at Medical Protection is that when patients are disappointed or dissatisfied, they are more likely to complain or consider a claim and compensation. So clearly, it's in all of our interests to take heed and involve patients as much as possible in the decision-making or consent process. So when we're driving on a long journey, human nature is such that we're more likely to be careful about our speed when driving if we know that there are a lot of speed cameras and we know that there's a higher risk of getting a speeding ticket along that route. So looking at patient clinical decision making, there are a number of situations, I think, where we have to be particularly careful in terms of medical legal risk. And our experience at MPS with complaints and claims highlights some of these higher risk situations. So perhaps counterintuitively, but elective situations can be more risky than emergencies. You would think with an elective procedure or an elective decision to start medication that the patient might have more time to make a fully informed decision. But because the patient elects to undergo the procedure, if consent is not fully informed, there's a greater risk that a complaint or claim will result following an adverse outcome. No one has to have an elective procedure ultimately. If you're taken into hospital with a perforated bowel and you need to have an emergency operation to save your life, that in some ways is an easier decision to make for a patient than the decision to have an elective, for example, hernia repair. Another area which is particularly risky is cosmetic procedures. So in addition to the issues that apply to elective procedures, failing to fully understand the motivating factors and desired outcomes for a cosmetic procedure can result in patient disappointment should the result not achieve what they are hoping for, and this can produce medical legal risk. Other areas that are potentially more risky if situations where there are multiple reasonable alternative treatment options with little difference in the predicted outcome. And clearly in those circumstances, a detailed discussion with the patient will be necessary to agree what is the best course of action moving forward. If they suffer a complication and find out there was another option which was perhaps less risky, they are likely to be unhappy. So we looked briefly at the risks associated with decision-making and consent. In the next section, we're going to focus on how effective clinical decisions are made. So we've already seen that patients want to be involved in decisions about their care. And as doctors, we can also have preferences about the way in which decision-making consultations are undertaken. And you might identify with one of these styles on the slide, or you may recognize that you vary your style depending on the situation and the patient. So on the left of the slide, we have the prescriptive or paternalistic approach, which assumes that patients should acquiesce to the doctor's recommendations and that information given to the patient should be minimal. This is really sort of the doctor knows best approach, which may have been more common historically. Then we have the informative approach, where the doctor sees his or her role as a provider of factual information, which the patient will then use to make his or her decision. And this is on the right of the slide, the more the patient choice. In the middle, we have a shared approach, where there is a recognition that both the doctor and the patient have information, opinions, and experience that they bring to the decision. Really, in this model, we're thinking that the doctor and the patient are equals in the decision-making process, leading to the options being discussed and decisions being made, taking into account the patient's beliefs, preferences, priorities, and values. This is really the shared decision-making approach, and we would suggest that this is the optimum way to reduce the risk of complaints and claims. And it's really interesting to note that although most doctors would say they prefer a shared decision-making approach, they do often revert to a paternalistic approach, especially when under pressure in terms of time or in particularly stressful situations. When we think about it, there really are two experts at every consultation: the doctor clinically and the patient subjectively. So the doctor brings the voice of science, knowledge, and clinical experience, but the patient brings their voice of life experience, expectations, values, and preferences. And shared decision-making combines and acknowledges the expertise of both the clinician and the patient. The concept of no decision about me without me is really important. Briefly going to touch on what your regulator, the Singapore Medical Council, expects. And they have outlined the principle of autonomy in stipulating the responsibility of doctors to provide accurate and sufficient information to patients so that they are able to make their own informed choice about their medical management. Doctors must respect the patient's choice. Ethicists have also noted the ever-expanding range of options and increased cost of medical care in a world of finite resources, and how these factors raise significant issues about healthcare decisions and the distribution of limited clinical resources. So, moving on, the Singapore Medical Council also say that doctors must provide the information that patients require in a way that they can understand so that they can make an informed choice. As we've mentioned, they must respect that choice, ensuring the patient has sufficient information to understand the consequences of that choice. So even if you disagree with the patient's choice, usually it has to be respected. They also say you must be aware that patients are made aware of the purpose of tests, treatments, or procedures to be performed on them, as well as the benefits, limitations, material risks that would be important to patients in their particular circumstances, as well as possible complications and alternatives available to them. So I think that guidance from the Medical Council is helpful. And of course, in the next presentation, we're going to hear about recent changes to the law on consent. But when we think about consent, I think there are a few particularly important points to consider, both from my medical legal work, but also from my prior experience as a surgeon. I think firstly, the guidance on shared decision-making and consent applies to all treatment decisions, not just those requiring formal written consent. So certainly from a family physician perspective, if you're starting a new medication, that is a consent discussion. It's not the same as consenting somebody for a laparoscopic cholecystectomy, but of course you're starting it can be a major decision for the patient. Secondly, obtaining patient consent is an ongoing process rather than a one-off event. It's more than just signing the consent form on the day of an operation. It includes any discussions you have with the patient about possible options throughout their patient journey. And treatment options should be carefully explained, including the risks and benefits, and that includes the no treatment option. That is a really important factor. If there is an option for the patient not to have anything done or not to start medication, they need to know the risks and benefits of that option compared with the alternatives. And as we've mentioned as well, doctors must try to find out what matters to that specific patient as part of your dialogue with them. So we've had a look at all the factors relevant to the medical decision-making process and consent. And I think it's fair to say that the research and the guidance from the regulator suggests that shared decision-making approach is best. This slide illustrates some of the benefits and impacts of shared decision-making and decision aids. It has been shown that shared decision-making approach can improve adherence to medications, improves communication between the doctor and the patient. This approach helps patients to arrive at a decision that's consistent with their values and improves patient knowledge and satisfaction. It's also been shown that utilizing a shared decision-making approach can cost less and use less resources. Okay, so far we have highlighted the risks associated with clinical decision-making and considered what contributes and influences effective clinical decision-making. And we're now going to consider the necessary skills to enhance the decision-making process for patients, whilst also reducing our own medical legal risk. And in particular, we're going to focus on ways to effectively communicate risk to ensure that our patients have an appropriate understanding of the risk-benefit balance, and then look at the key skills required by us to facilitate shared decision-making using the 6D medical protection model. So what do we mean by risk when we are discussing treatment options with our patients? Well, usually we mean the risk of harm occurring, where harm is any negative outcome, including a side effect or complication. And in general, we have three ways of describing the level of risk to our patients: verbally, numerically, and visually. And when we think about verbally, we might say something like, there is a very small risk of damage to your common bile duct during this keyhole operation to remove your gallbladder, or a surgeon might say that. And the problem with something like this is that if we say there's a very small risk, very small might mean different things to different people. And a 2002 study in the Lancet in the UK showed that when a doctor described a complication as rare, patients estimated there was an 8% risk of it occurring, whereas the actual risk was between 0.01% and 0.1%. So quite a stark difference. So your perception of what very small might be very different to your patient's perception. And that brings us on to describing risk numerically. And going back to my surgery example, the risk of common bile duct damage in a lap chole is often described as 0.3% or 3 in 1,000. Now, if your patient is a professor of statistics, they're likely to be able to understand and process what that means. However, across the general population, percentages are poorly understood. And it has been said that only 50% of the population understand what 50% actually means. So it's something to keep in mind. Looking at the slide, other pitfalls include using different denominators. For example, comparing 15 over 100 to 2 over 10. Some patients might not understand that 2 in 10 is actually the higher risk, not 15 in 100. So I think you have to be a bit careful about using statistics. The other way of demonstrating risk is visually. For example, you could use a pie chart, such as the one on the slide during the consent process, or again, use pictures or diagrams to explain the procedure or risks. And research has shown that using visual representations can greatly enhance understanding. Overall, it's likely that successful discussion will include a combination of the methods I've mentioned. And importantly, it will need to be tailored to the individual patient in front of you. There is no standard script for a consent process. I think this slide's interesting. How risk is described can greatly influence patients' decisions. Gurn's study in 2000 demonstrated that 27% of patients would definitely or probably undertake a procedure if it was explained that complications are seen in 1 in 100 people undergoing the procedure. However, if they are told that 99% of patients undergoing the procedure do not have any complications, 52% say they would definitely or probably go ahead, which is quite an increase from 27 to 52%, the same statistics, but described in a different way. So we all have to be aware of how our patients' understanding can be affected in this way because of the way that we frame risk. It's also important that no matter how risk information is presented to them, a patient's perception of risk will be affected by other factors such as their personal preferences, their emotional state, and the meaning that they may attach to a particular outcome. Decision aids can be a useful part of the decision-making toolkit, and it's worth considering using them. So that's things like patient information leaflets, videos, internet-based tools, and patients can use them before, during, or after face-to-face meetings with their health professionals. Well, they can use them on their own without any connection to a health professional. I remember as a medical student in Newcastle in the UK, being incredibly impressed. I was fortunate enough to spend some time on the children's heart unit where they were doing incredible operations for congenital heart disease. And I always remember that the senior surgeon there using various models demonstrating the congenital heart defects to the parents of these tiny babies undergoing complex surgery to explain what they were required to do in terms of the surgery. So there is an important place for decision aids. Right, we're now going to look at our 6D framework for shared decision making, and this will hopefully allow us to think about some of the key skills required to facilitate a shared decision making approach. So the 6Ds has been developed by Medical Protection to incorporate the key skills to achieve effective shared decision making. And the 6Ds stand for developing trust and discovering the patient's views and values, discuss the options, benefits, and risks, double check understanding, make a decision, and document that decision. So our first D is for developing a trust, and building trust may be the single most important task in the whole shared decision-making process. Even if all the other communication tasks were fulfilled, if the patient does not trust the doctor, it is highly unlikely that they will reap the benefits of the shared decision-making process. So firstly, a reminder of some important basic communication skills that help to build trust. So some examples are connecting with the patient, reflective listening, summarizing and clarifying the patient's opinions and perspectives, showing empathy, and inviting questions. And these are all things that family physicians in general are very experienced in and have a huge amount of experience in, more so sometimes than some of our hospital colleagues. Secondly, there are important strategies in any decision-making process that help to build a positive, trusting doctor-patient relationship. And these include really involving the patient in the decision and asking how much and what sort of information that particular patient may want. As discussed earlier in the workshop, there's a benefit from encouraging passive patients to contribute to the decision-making process, and they may need some encouragement to do so. And as doctors, we need to develop strategies and questions to really discover and understand the patient's perspective and what's going on inside their head. We'll have a think about some possible phrases that you could try to use when we talk about the next D, discover. Patients who actively volunteer information from whatever source should be encouraged and actively heard before moving on to discuss options. Some doctors see these more active patients as a threat to their professionalism, and we should try really to reframe our perspective and consider how useful it can be to have a patient who is well informed, has considered the options, reflected on their preferences, and is willing to contribute to the shared decision-making process. And we really need to try and avoid any tendency to feel that a patient has been awkward by asking lots of questions. So it's vital to know what matters to the patient before starting to offer options or discuss the risks and benefits. And that's so that the discussion can be tailored to that individual patient. It also helps the patient to assess the likely impact, the potential outcomes of each option for them. So you might want to say, start off by asking, what do you already know about this? Do you have any thoughts about your condition or its treatment? What worries you the most? Is there anything else that you're concerned about? Asking about their expectations. So what were you hoping for from treatment? What would be a good result for you? So these are all the sorts of questions we can ask to discover what our patients are hoping for. The next D is for discuss, and here we want to stress using a process that openly considers and analyzes the options open to the patient. So a full discussion of the available options, including the no action option, is an essential part of this process. So that includes a discussion of the purpose, nature, likely outcomes, uncertainties, and risks and benefits of each option, personalizing the information to that particular patient as much as possible. And this should all be done with respectful regard for the important values that the patient holds and focus on the risks you anticipate this particular patient will regard as significant. Our next D is for double-checking understanding, and this is absolutely essential. You may have explored the patient's views, provided what you thought was a brilliant explanation, but if the patient hasn't understood and you don't identify this, there is a problem. They might subsequently allege that they hadn't been adequately warned should a complication develop. So checking patient understanding incorporates the concept of closed-loop communication. So that is the deliberate verbal repeat back of information with the double benefit of allowing the patient to process the information by verbalizing back out loud the key content. It provides reassurance to both the doctor and the patient about what has been understood by the patient. And it gives the opportunity for the doctor to reflect on the information given and gives them the opportunity to amend it. And one of the challenges for doctors to develop phrases that enable this process of confirming understanding without making the patient feel uncomfortable. And this study, the study mentioned on the slide by Kemp et al., looked at which approach to assessing understanding of medical information patients most prefer and perceive to be most effective. And 3 models were looked at: the yes-no model, the tell-back collaborative model, and the tell-back directive model. And the studies showed that patients strongly prefer the tell-back collaborative form of inquiry. So yes, the sort of yes-no approach is not really helpful. If you ask a patient, do you understand? Even if they say yes, you don't really know that they've actually taken in the information provided. Tell-back directive can be a bit confrontational. This is when you say to a patient, can you repeat back to me what I've just told you? So, you know, if you come across as slightly you know, patients want to try and please you as their doctor, but that kind of approach can be a bit aggressive. Tell-back collaborative is a softer approach that's more likely to engage the patient. For example, you could say something like, I've given you a lot of information today. It'd be really helpful for me to hear your understanding about your condition and its treatment. An alternative approach might be to say, when you go home this afternoon, what are you going to tell your partner about what we discussed here in the clinic today? The other factor to bear in mind is if the patient has misunderstood, the doctor should take the responsibility for not having explained it adequately, rather than implying that in some way it's the patient's fault that they haven't taken in the information. Our next D is for decision, clearly an important part of the process. And the first thing to consider is that unless an extremely urgent decision needs to be made on clinical grounds, think about whether the patient is ready and comfortable to make a decision. Alternatively, a decision may be deferred until he or she is ready to allow until they're ready to make the decision. They might want to discuss with their family first. It's important to agree next steps and arrange when you will meet the patient again. When a decision has been made, remember this can be reviewed or revisited at any stage during the treatment journey. Most regulators make it very clear that you should regularly review patients' decision. So if, for example, a procedure has been agreed on at the clinic, that decision needs to be reviewed immediately prior to any intervention, particularly if a period of time has passed or if you haven't seen the patient personally before. Our last D is for documentation, and no talk from medical protection would be complete without reminding you all of how medical records are vitally important when it comes to defending you in the event of a complaint or a claim. From a medical legal perspective, a signed consent form is of little value unless the information which the patient made the decision to sign the form is also documented. So this includes documenting what the patient said was important to them in making the decision and noting that you checked their understanding. If initial discussions regarding the treatment occur in the clinic, consider sharing a record of the discussion and decisions by providing a copy of your letter detailing the discussions with the patient. Also include details of who to contact if they have any further questions. If further discussions occur at any later stage of the process, it's important to document these as well. And as I said, fundamentally, thorough documentation will protect you if subsequent allegations are made about the consent process. So that's our 6D framework for shared decision-making. Developing trust, discover patients' views and values, discuss the options, benefits, and risks, double-check understanding, make a decision, and document the process clearly. So all that's left for me to do is to summarize the key messages we have covered in today's presentation. So clinical decision-making carries significant medical legal risk, and that relates to the quality and quantity of information exchanged, the decision-making process, and unmet treatment expectations are a source of risk. Shared decision-making is likely to reduce the risk, and the 6D framework will help to ensure that the key communication and documentation tasks of shared decision-making are undertaken. And I think we're just about on time, so thank you to listening to my presentation this afternoon, and it's my pleasure to hand on to our next speaker.
Thank you very much, Dr. James. So thank you for bringing us the first segment, and I hope the 6D model will give all of us a good framework to approach consent taking for shared decision making in primary care. So for the next talk, we have Mr. Lake. Mr. Lake is a lawyer and senior partner in Dentons. He specializes in medical law. I'm sure many of us are very familiar with him. He has been giving many talks to the medical fraternity. He has been representing and advising doctors, dentists, hospitals on legal, regulatory, and ethical issues, and also defended doctors and hospitals in malpractice cases in courts and in other proceedings such as the coroner inquiry, SMC, disciplinary tribunal inquiries, and the Singapore Dental Council disciplinary committee inquiries as well. He's an honorary legal advisor to the Academy of Medicine Singapore and the College of Family Physicians Singapore and the Singapore Medical Association, and he was conferred honorary membership of the college in 2014. Apologies. So without further delay, I'd like to invite Mr. Lake to give us the next talk on the change in the law of medical advice and consent, the Civil Law Amendment Act 2020. Mr. Lake, thank you.
Okay, can you see the screen?
Yes, we can.
Yes. Okay. Good afternoon, ladies and gentlemen. So today I'm going to talk to you about what the present law on consent is in Singapore. Okay. Now, of course, Dr. James Thorpe has brought you through the process, from a clinical standpoint, how you should go about getting a proper consent, what are the important things to remember. Now, but when in Singapore, we have to understand that there is a legal requirement to obtain a valid consent before you actually provide the treatment. If you fail to do so, you can actually expose yourself to liability in medical negligence. Okay, there's also possible exposure when you treat a person without prior consent in assault, and there's also potential criminal liability. There's also the issue of professional ethics. If a doctor does not obtain a valid consent before treatment, then he is possibly exposed to a charge of professional misconduct under before the Singapore Medical Council. So some of you all may remember the infamous case in 2018 of the surgeon who was charged by the Medical Council for not obtaining a valid consent before administering a H&L injection, right? So that was unfortunate saga. It has some impact on the current situation that I'm talking to you about this change in the law. Now, before talking about the substantive matter, just to have a bit of understanding about what constitutes a valid consent. There are actually three elements to a valid consent. The sufficiency of information given to the patient, that's the advice portion. The patient must understand the information given, and the consent must be given voluntarily. Now, today, the focus is on the first bullet point, the sufficiency of information given. Now, to understand where is the law of consent found, Singapore being a common law country, okay, this area of the law of consent in the context of medical negligence is actually was originally under common law. So common law is judge-made law. That means judges deciding a particular case on this subject matter, they will lay out the principles of law. And so that's where the law in common law is found. So in Singapore, prior to the statutory change under the Civil Law Act, okay, it was understood in an earlier period that this is covered by the Bolam test. So the Bolam test is the test of a reasonable doctor. That means the question is, what sort of information would a reasonable doctor in that setting tell the patient for the purposes of getting a consent? So it's a test of a reasonable doctor. But over time, there was doubt raised in various cases as to whether the Bolam test is necessarily appropriate for consent taking. So various other common law countries actually made changes to this the application of the Bolam test for consent taking. So Australia, Canada, Malaysia, they through case law, they changed the law. And then in the UK in 2015, there was the famous Montgomery case. Okay. Now this Montgomery case, I mean, some of you would have heard the language in the context of consent. Now, so in Singapore, if you look at the slide, right, our highest court, the Court of Appeal, in the decision of Hitchcock, adopted a new common law test for what constitute valid consent. All right. They didn't bring in the entire Montgomery test, the UK test, but they used a modified version. Now, the perception after this decision came out, the Hitchcock case, it was felt in some quarters that, hey, this looks like a very patient-centric test. What has happened to the reasonable doctor test? Okay, so essentially, the Court of Appeal introduced a three-stage test, and from the way that they elucidated the principles in the case, they asked whether the information was material from the perspective of a reasonable patient. Okay, that means would a reasonable patient consider a particular piece of information sufficiently material that the doctor needs to actually advise? Okay, alternatively, was it information that a patient in that particular patient sitting in front of the doctor would actually regard as material for his own reasons? Anyway, the long and short is that there was concern about this test, the reach of this test. Now, as a result of the concerns that were expressed, right? That were expressed, and also in the light of the Dr. Lim Lian An case, there was question as to whether this new test which our local court introduced through the Hitchcock case was actually appropriate. For the lawyers who are familiar with this view, we actually don't find that it really changed the law very much. Okay, but there was certain language in the decision that gave rise to concern. Anyway, long story short, the government decided that they want to make some modifications to the legal test, which was laid out in the Hitchcock case. And this was by way of a statutory amendment. you remember, right? I mentioned to you, our law on consent used to be found in common law, the judge-based kind of test. That means you look for the test in a judgment. But because we are not about to wait for another court to decide a case, okay? Because the case might never come for another 10 years, all right? A suitable case, a similar case for them to pronounce on. So our government decided that they will codify introduce a change in the law by way of legislation. That means the law can be found not just in common law, but also in legislation. So our parliament can actually set out the law by way of legislation. And the legislation that they chose to use for this purpose is the Civil Law Act. So they did an amendment to a piece of law. This Civil Law Act, don't worry too much. It's just a very general statute that dealt with different areas of personal law. So they inserted a new section 37, okay, dealing with the area of advice and consent. It doesn't change the other common law tests relating to issues of diagnosis and treatment, but for the area of consent, through this amendment act, they simplified the law, and there was explanation as to before Parliament as to why they wanted to have a change in the law for this. Okay, so what does Section 37 actually look like? So not to worry. Let me quickly show you what it looks like first before I lose you. So don't worry. I'm going to just show you what it actually looks like before going through the relevant portions. So after this talk, I think the materials will be disseminated to you. You can actually find that Section 37 of the Civil Law Act, which deals with this, the present law, is actually quite well drafted. It's quite simple. And this is what it looks like. So it's Section 37. There are a few subsections, 1, 2, 3, and that's it. That's it, So I encourage you to go and have a look at it yourself. You can find easily online. And this is what it looks like. Okay, now I will go back and draw out for your attention the key portions of this new law. Okay, so essentially, right, this Civil Law Act amendment, Section 37, it deals with what is the standard of care which a doctor must meet in order to obtain a valid informed consent. So you look at Section 37, 1A. Okay. A doctor would meet the proper standard of care for medical advice if the manner in which the healthcare professional acts in the matter is accepted by a respectable body of medical opinion as reasonable professional practice in the circumstances. So the key new language that is introduced by this act is the proper standard of care is that which is met by accepted peer professional opinion. Professional opinion. And it is also, that opinion must also be logical. So you might wonder, why is this language so archaic looking? Actually, Section 37, 1A, that is actually an iteration of the old Bolam test. Okay. B is the Bolito amendment to the Bolam test. So the start point for this so-called new test is actually the old test, the common law test. But of course, they explain what qualifies as peer professional opinion. So it starts to feel a little bit like the good old days, except okay, the parliament still wants to recognize, okay, the primacy of patient autonomy. Okay, but at the same time, they want to have regard to the fact that the practice of medicine is a specialized field. Okay, they want to uphold the principle of self-regulation of the profession. So the opinion of the profession in the field, in the particular field, is important. At the same time, there must be logic and reasonableness. So what qualifies as, okay, peer professional opinion? Okay, basically, the start point is, and this is in the section 37(2), they will ask, the start point is that a doctor must give opinion, give information that a typical reasonable patient would require. So in a sense, this is like the doctor must act reasonably by giving information which a reasonable patient, okay, sitting in that position with the kind of diagnosis would expect. So this is where the doctor's input as a body of opinion must provide. But that's not all. Okay, if you look at 2, in addition, the doctor must also give information that he knows or ought reasonably to know is material to the specific patient in front of him. So this is actually to cater for the fact that there may be, okay, for want of a better word, idiosyncratic situations that a doctor cannot ignore. Okay, it is perhaps easily, I will illustrate it in this way. Let's say a doctor, a hand surgeon, let's say, before operating on a patient when taking consent, right? He might have his standard set of risks and complications to be given to a patient before obtaining consent for hand surgeon. But the test tells us that you must also be aware that there may be more than the usual. Okay, and this is dependent on the specific patient. So if the patient, for example, is a professional concert pianist, so his hands are, of course, so important to him, much more important than the so-called normal person in the street, right? Then, because of that particular patient in front of you with this particular feature, right, the doctor has the need to go into a bit more into the discussion of even the risk which an ordinary patient may not actually be expected to be interested in or consider as material. But a concert pianist who uses his hands for a living, right, might see things quite differently. So for that kind of patient, you must, in simple language, you must tell more. So for that same reason, right, maybe a hand model. Okay, scarring might be a major thing for a hand model. All right, so basically, when the law deals with the typical patient, they also provide for patients which are specific, different, a bit different. At the same time, the law also wants to deal with the situation that cater for the situation where the doctor need not tell certain things. Okay, so there are information that might be required, but at the same time, they also make clear that sometimes there are some information that sometimes certain situations where the information need not be given. However, a simple rule of thumb is this. In the course of decision making, the doctor may have a certain set of advice. But when a patient asks specific questions, okay, the doctor needs to address them. The doctor is not allowed to say, sorry, this is really a bit weird and weird. I don't want to talk to you about it. So they actually deal with a situation where if specific concerns are raised, the doctor cannot ignore. Okay. So this test, we are still actually back to the reasonableness principle. Okay. And one of the things about specific patients is that came out in the course of the passing of this law was that, hey, with medical records, and then with electronic medical records, you can actually have access to more information about the specific patient. How important, what is the place of this additional information? All right. So in the passing of the law, the second minister for law at that time did say that we have to deal with this in a very commonsensical manner. Yeah, the doctor is not expected, even though he has probably the ability to have access to 10 years worth of record, to go and scroll through everything. Okay, so that means, I guess he's saying that you need to deal with it in a very commonsensical manner. The Act also deals with situations where there are reasonable justification for not providing information. So the classic situation of emergency. They also address the situation where a patient has actually waived the right to information. All right. However, it doesn't mean that a patient simply tells the doctor, I don't need to know. The doctor can just accept it at face value. The doctor still needs to be satisfied that the patient in front of him or her actually understands the seriousness of the situation and the decision to waive. Okay. There is an illustration of the classic situation, which sometimes we do hear. A doctor will say that, hey, I cannot tell this patient too much. The old uncle will simply run away and not seek treatment, even though he needs the treatment. So anticipating this type of thinking, the law actually provides a specific illustration. Okay, that while it is in the best interest of a patient to undergo a procedure, even if the doctor believes that telling that patient would dissuade him from undergoing it, this is not a justification for not informing the patient of the risk. Okay. All right. Now, so essentially, what is the situation with this law? So this law has come into force, okay, since the 1st of July 2022. So what this means is that these new principles that we just went through is now the law of the land for cases starting from 1st of July 2022, so relatively recent, 2 years ago. However, so that means basically if consent was taken for a patient before this date and the treatment is completed, the old law, the Hitchcock, the common law test in the case of Hitchcock still applies. All right. Just to confuse the matter a little bit, but if the consent was taken prior to the 1st of July 2022, but the treatment is not completed yet. All right, that means the treatment stretches across the date of 1st of July 2022. Then for those type of cases, when you test whether the consent is a valid consent, the new law applies. Okay, I repeat, new cases from 1st of July 2022 onwards, new law applies. Cases where consent are taken, okay, treatment given, completed before the 1st of July 2022, the former law applies. Why do we worry about those? Because court cases take a long time. So you might have a 2021 case, but the case may not be completed in the courts until 2025. Then the applicable law would be the old common law test. Okay. I guess I'm just mentioning to you lah. So because even though I said new law, but actually the old law is still relevant in certain contexts. Okay, but don't worry so much about that. I think in the great majority of cases, the difference is not that significant. But the wonderful thing really is that you now have a codified provision where you can take a look at it. It's not too difficult to understand, and best of all, it's only contained in a couple of pages, unlike the old provision. So I suggest you take a look at it. Then you can have a better understanding of what the new law is. Okay. This ends my presentation.
Thank you very much, Mr. Lik. So I hope the first two talks have given us a broad idea about the principle of consent using the 6D model, and then now having an understanding of the local context in which medical practitioners practice in, and what are some of the legal requirements or standards when it comes to about consent. So with that in mind, we are running just a little bit behind time. We'll have a short 5 minutes break. It's about 3:15 p.m. So we'll take a break up to 3:20, and we'll come back, and then we'll then use what we have learned from the earlier two talks to then apply to some of the case discussion that we'll talk about consent in primary care. I've also noted that there are some Q&As highlighted. Keep it coming. We'll answer them at the end. Okay. So without further delay, let's go for the break. We'll see you back in 5 minutes. Hi, welcome back, everybody. We're just slightly over 3:20, which is slightly over about 5 minutes. So I know it's a short break, but we do have a packed program, and I hope you had some time to take a breather during these 5 minutes. And without further ado, let's move on to the next segment on the case discussion. So for the next segment, we would like to invite Dr. Uzair to lead us in the next segment. Dr. Uzair is the medical legal consultant at Medical Protection Society. He graduated from medicine from the University of Malaya and previously held positions of a senior principal assistant director in the medical legal section, medical practice division in the Ministry of Health, Malaysia. He's completed his master's in law at Kent, University of Kent, and did a dissertation titled The Impact of COVID-19 Towards the Standard of Care in Medical Negligence. Previously, Dr. Uzair held the position of Vice President for the Medical Legal Society of Malaysia, and he's currently a medical legal consultant with Medical Protection Society as part of Team Asia, Caribbean, and Bermuda. So, Dr. Uzair, let's do take us to the next section. Yeah, over to you.
Thank you very much, John. Let me just get my slides up. Do let me know if it's showing all right.
Yeah, we can see your slides.
All right. So I'm going to discuss two cases with regards to consent in primary care. I've been having a look at the questions, and these are really interesting questions, and I look forward to answering them at the end and as we go through. This is a forum discussion, so I merely pause and get the panelists to give some input as well. Without any further ado, let's go on. And this one we mentioned in the beginning. If you're not a member yet, please enjoy this discount and join us as soon as possible. So the first case is a dog bite wound. This is a Singapore case. I'll go through a bit of the summary of the facts of the case. It's a 70-year-old male. Mr. D, he was bitten by the family dog over his forearm. He visited the GP, no other injuries. On examination, there was a 3 cm lateral laceration with a 1.5 cm laceration on the medial aspect. So what did the GP do? The GP cleaned the wound with chlorhexidine and proceeded to close the wound with Dermaflex, which is adhesive tissue, sort of a glue adhesive. Tetanus was given, and the patient was given antibiotics for a week. And what was the advice given to the patient? To change the dressing if it got dirty or wet, to seek treatment if wound become red, painful, or if the patient developed fever. And there was no discussion on treatment options. So what happened next? The next day, the patient noticed that the wound became red with blisters, and he went back to the clinic, which was unfortunately closed at the time, went to another clinic and was informed that the glue should not have been used, and the patient was referred to the hospital. At the hospital, unfortunately, the wound became infected. He was in the hospital for 4 days, and after that was discharged with no long-term complications. The patient lodged a complaint towards the doctor. Initially, the doctor was very defensive and insisted that the choice of glue was appropriate. And then the patient lodged a complaint to the medical council. So I'm gonna pause here, and maybe Dr. Chong, maybe I'll go to you first as a GP. What do you think about this sort of treatment given by the doctor? If you have any thoughts.
Hi, thanks, Dr. Uzair, for the question. I think in this case that it was unfortunate that a adverse event occurred. While we don't have the exact facts of the case, I think in this case is that essentially the doctor appeared to have to proceeded with the procedure and did not have the opportunity to discuss with the patient regarding the options, the risks and benefits. Especially in cases where there could be a range of opinions about what could be the standard of care, I think it's equally important for the doctor to discuss with the patient about the treatment options and what would be the recommended treatment, and seek the patient's perspective and consent in shared decision making. Yeah.
Yeah, and I'm gonna go to Mr. Lek and get your views on how important it is to tell patients about the treatment options, or maybe perhaps even no treatment. Is that an option as well?
Yes, there is a duty to talk about treatment options, reasonable treatment options, provided in fact actually there are reasonable treatment options. If there's actually no treatment option, but there's only one path, all right, then that should also be mentioned to the patient. But of course, the doctor must be able to substantiate his position. Now, in this case, the question here, the issue is that the wound became red with blisters. Okay, then of course, the doctor should meet the standard of care by telling the patient that this particular treatment carries with it perhaps certain types of complication, or no, the kind of reaction, skin reaction, or risk. Okay, so what needs to be told is what is regarded as necessary by your fellow respectable body of your peers.
Okay, yeah, thank you. And I'm gonna go to Rob. Is it common to see other doctors telling the patient that this sort of treatment shouldn't be done, or is it also common for a patient to escalate from a complaint to a medical counsel? Rob, in your views.
Thanks, Azar. Sadly, one of the commonest reasons we do see complaints being lodged is where the trust in the care that's been given is undermined by someone else. So I think, most almost as a part of a sort of professionalism, it's not great choice to be complaining or saying to patients that another doctor has made a poor choice. Because, of course, the fact of the matter is when you're seeing a patient later, you don't always know what the doctor who was treating the patient had before them at that time. So it sadly, as I say, it can be. And I think it comes back to what we've talked a bit before about in this webinar about both building trust, but in this situation, if that trust is undermined, it's much more likely patients will feel dissatisfied and raise a complaint or a claim.
Yep, thank you, Rob. So let's see what happened next. So what was the doctor's views? So the patient had just received the bite. The wound was not deep. There was no sign of infections at the time, and the glue would have been given a better cosmetic outcome. So that was the doctor's point of view. And when he went to the medical counsel, and Mr. Lek, maybe I'll go to you later on after this about what are the procedures in the medical counsel when it comes to, and I think expert is a really important point of view, as you mentioned, even in your talk, you need to be the standard of an expert of similar profession. So the expert said that the application of tissue adhesive was inappropriate, and it increased the risk of wound infection, and particularly because it is a dog bite, it was viewed that the wound should have been sort of left open. That was the view. And even if you look at the information sheet of the glue adhesive, it had not been studied for animal bites. And another adhesive, which was also brought to the court, said that it should not be used for animal bites. But the one that the doctor used said that it was not been studied. And then what happened next is the complaints committee determined that the doctor had inappropriately managed the wound. There was insufficient evidence that the doctor deliberately departed from the standard of care or displayed such serious negligence, and then a letter of warning was given. So Mr. Lek, maybe you can just give us a brief summary of what sort of happens in the medical council with these sort of cases.
Yes, so I want to point out that medical counsel cases for professional misconduct are actually quite different from a civil case where the patient makes a claim, okay, for negligent treatment and claims compensation. Okay, so medical counsel cases in professional misconduct, and in this case, professional misconduct for, I suppose, inappropriate treatment, all right, is is probably very simplistically put, can be said to be a higher standard. So the medical counsel may, in this particular case, find some reason to let the doctor off, okay, or on the charge. But I doubt if this doctor, if indeed the treatment was inappropriate, would actually be able to escape liability before the courts in a civil case. So it's just to understand that, of course, in the context of this case example, they are looking at a SMC case, quite different in a civil case.
Yeah, and I think you raise a really important point that there are different standards of the burden of proof and all that when it comes to regulatory versus civil versus criminal, and the doctor should be aware of this. And I'm gonna go to Rob. One case can lead to multiple jeopardies. Would you want to say a bit more on that, Rob?
Thanks. Yeah, I mean, I think you're absolutely right. Where something goes wrong or is perceived to have gone wrong, the patient or their family can follow more than one avenue, as you say. And I think, we've talked in this case about the fact that they would have been perhaps looking for damages in a civil court, looking for money to compensate them, but also going to the medical council to complain. And indeed, as we say, it may just be a simple complaint to the practice as well. If the patient had died, obviously there could have been other things going on. So I think, sadly, one of the problems with being a doctor in any of the countries we work in, the way they can be held to account can be numerous, so that time taken in building that trust and making sure that the patient understands what they're agreeing to can ward off a lot of problems. And as we keep stressing the importance of maintaining good records, so that should something go wrong and should you be asked to account for your actions, there's some good evidence that we and our solicitors can bring to bear to defend you in the different forums.
Thank you, Rob. And this is the last slide for this case, but we're going to have a bit more of a discussion. One of the pertinent things was that there was no discussion with the patient on the treatment options. There was no documentation regarding the advice given, and then this case proceeded for the patient was unhappy with the SMC outcome and went for, as you mentioned, for compensation via the lawyer's letter. I'm going to take a pause here. And I did look at the questions. One of the questions was with regards to consent, whether all consent needs to be in a written form or can it be a verbal form. And then in this particular case, there was no written consent. Maybe I'll go to Dr. Chong first, and maybe you can enlighten us of the practice in Singapore. Are there procedures where there are forms and procedures where there are no forms? Maybe you can share with us that.
I think in principle, I think we have to, I think as spoken on by Mr. Leg and also by Dr. James, I think consent is a two-way process, it's a continual process. I think the moment the patient comes and see you and you establish a patient-doctor relationship, there is already some form of consent taking place, that the patient has consented to come and see you, and from there it is a continual process. And within this patient-doctor relationship, there's this constant, process of information transmission, judgment, and decision-making that goes on both by the doctors and the patient. But of course, when we look at consent in medical care or in medicine, there are many types of consent. There's explicit consent, and there's also implied consent. So I think it will be good to understand, for us to have a idea of what type of situations that explicit consent would be necessary, and in what situations that implied consent would be sufficient. And I think that comes from many. We can look at it from various aspects. I think one, of course, is to understand our local social, cultural context and the legal framework that we operate in. Certain procedures, especially that may be more complex, that necessitate significant disclosure of information, have a greater impact, especially when it comes to material risk, probably should be explicitly discussed, documented, and maybe even formalized in a formal written consent form. And I think common situations would be such as surgical procedures, invasive procedures, medical research, and medical reports. So I think having an understanding of what's the legal and the medical legal framework that we operate in would be important. So that is somewhat like what the Bolem and the Bolito is, what would be a reasonable doctor do. Then, of course, I think at the same time, each individual doctor may have his own framing of what are the particular risks that he or she may perceive. And in this situation, the doctor may choose to, move beyond to actually have certain verbal consent or written consent for certain procedures. Then I think the last part is about, of course, the patient itself. So depending on the patient and maybe your assessment of what is the patient's values, preferences, and also the patient's what is material to the patient, sometimes you may also wish to want to have a written consent with the patient for certain issues. But having said that, not then the question is, I think it was also asked in the chat, do everything needs to be consented and written down and documented? I think that's where we have to take.
I think that's where I would like to get Mr. Lake's view on that particular point.
Yeah. So this query also came up in one of the questions. Let me explain it in this way. Before treatment, in every case, there must be consent. You understand? You cannot give unconsented treatment. The consent can, of course, be expressed or in some cases implied. So let's say, for example, I'm going to, I agree to do a blood investigation. Okay. So when the blood is drawn, okay, even though I didn't expressly say, yes, I agree to blood being taken from me, there's at least implied consent because I agreed to this line of investigation. But in every case of treatment, there must be consent of some sort, expressed or implied. Documentation is a different thing. You need to understand that there is a legal requirement for an institution, a licensee, okay, of a medical institution to have documented consent for treatment. You understand? So that is a different thing. And for an individual professional, it is an ethical requirement under the SMC ethical guidelines that you must document consent. So understand that it all comes from different things. At the same time, the documentation of consent doesn't mean that in every case the patient must have a signed consent. It's a different thing. You understand? So I illustrate with this example. So discussion in the clinic setting for treatment, and you don't have a process for a patient to sign a consent form. Okay, simple process. You can simply write down, discuss with patient, blah, 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 patient consented. So that is already documentation of the consent, you understand? So it doesn't mean that in every case, you must have a signed consent. Of course, if you have a signed consent, that's all wonderful, right? Signed by the patient. At the same time, also understand that if you work in a healthcare institution, your institution may have certain mandatory requirement for patients to have assigned a specific consent form for the surgery. So that one, of course, as if you're working in an institution, you have to follow the procedure because it will be very odd, right? You cannot say that, hey, patient agreed. Okay, I might even have a recording of him. Okay, that's different thing. But if you didn't obtain a signed consent when the institution requires to, my goodness, you have a lot to answer for. Okay, you'll probably hit on your head for not doing so. But understand it's different thing. All treatment, you must have consent. You cannot treat without consent, except for emergency situations. I leave those examples. Documentation is a requirement, okay? But it doesn't mean that signed consent of the patient is required in every case. It's actually quite different things.
Yep, and I think you explained it really well, and we do see this in the cases that come to MPS as well, whereby we have managed, in fact, to defend the case where there was no signed consent by the patient, but we still managed to defend the case, and the court looked at other things as well, looking at and consent. I always say is a process. If it's a elective procedure, you have multiple opportunities to explain to the patient, and it's all of sort of all leads up to the procedure itself. So it's quite interesting, and thank you very much for that. Um, yeah, I'm going to move on to the second case scenario. We don't have much time, and I did see a comment. Someone was commenting about I should have given a bit more description about the bite, and I apologize for that. We don't really have much time, so I'm sorry for that. But moving on. The second case is an allegation of sexual assault, and you'd be surprised how many cases we see being brought to MPS with regards to this, especially in the general practice setting. Let's go through the facts of the case briefly. Mrs. T presented to the GP with a complaint of cough and runny nose for 2 days. The doctor was called to review the patient. A history was taken. The patient consented for physical examination. Patient was brought to the examination bed with curtains, and auscultation of the respiratory system was done. 3 days later, the clinic is contacted with allegation of inappropriate touching. 4 days later, the police requested an interview in relation to allegations of sexual assault during examination. What happened next? The doctor contacted MPS for advice, and we assigned a medical legal consultant, such as myself, and we also got a solicitor, like Mr. Lek here. And we took the doctor's views, but sometimes the doctors can downplay the seriousness of these allegations. Maybe I'll get Mr. Lek to weigh in on that. And the doctor felt it was obvious that the patient misinterpreted the examination. However, we explained that there are very potential serious consequences. The doctor was clear he hadn't deliberately touched the patient's breast, or was there any sexual motivation. He said he may have inadvertently touched the patient's breast during the examination, but it would have been accidental and fleeting. So I'm going to take a pause here, and Mr. Lek, can you tell us what are the sort of potential consequences of something like this sort of allegations?
Yeah, I mean, unfortunately, we do get this every once in a while. Okay. Some of it is in the course of doing an exculpation. Most of the time, I guess the doctor needs to read the patient. Okay, you need to read the patient, and sometimes it may just be helpful for the doctor before starting the examination to just mention what he is going to do. Okay, I know people, is maybe you're not taught to do so, but I always feel whenever I deal with some of these cases, that just a word or two, and see how, if the patient reacts funny, then maybe you want to call for a chaperone or something, even though you are not asking the patient for any sensitive parts to be exposed or partially exposed. Okay, so you need to, in a sense, read the situation. This type of medical examination kind of situation is when a patient comes to consult you for a illness, okay, I find very much less complaint cases arising out of those. The type is that I get a lot of complaint, the pre-employment examination cases. Okay, because a doctor explained to me, he said, Mr. Lake, it's like that because the person who is coming for a pre-employment actually doesn't want to be subjected to a medical examination. So already not happy, already in a sense, not very happy trooper. So at the slightest thing, that person may actually just complain because she might not truly understand that the examination may need to be a bit more comprehensive. So she didn't expect it, and then we have another complaint. Okay, so of course, if the doctor, the simplest thing is scenario would be that where some degree of exposure, partial exposure may be needed or near, then please male doctors get a chaperone. Okay, you might say clinic staff difficult to hire, but sorry. The kind of, you just get yourself into a bit of a border. The police investigation can take quite a while, unfortunately.
Yep, that's very true. And let's see what happened next in this case. So on behalf of the doctor, we instructed the solicitor who draft a statement for the police in incorporating a detailed description. And we've been doing this a long time, so we know what are the things to be written inside. And interestingly, in this case, although there was a chaperone during the initial examination, the chaperone had left the examination area to take a phone call during the physical examination part. So I think it's important to have a chaperone and to make sure that the chaperone stays throughout the examination. So what happened next? The statement was submitted to the police and they arranged to interview the doctor. And fortunately, in this case, the police closed the matter with no further action. The patient, being unsatisfied with the outcome, proceeded to complain to the medical council and then posted on social media and so on. So, Mr. Lake, you want to give a little summary about police investigation and how, what should the doctors be prepared or, what are the sort of
so
things?
if you unfortunately receive you're on the receiving end of such a situation, you are being called in for a police interview. Do notify, if you're a member of MPS, please of course notify MPS and request MPS to assign a lawyer to advise you. There are certain process steps that your lawyer should be able to advise you on before going for the police interview. There are certain safety steps that you should take because you never know in what direction the case is going to head. So we will give you, the lawyer will give you some advice about how to deal with the interview process and what to look out for. Okay.
Yeah, and I'm gonna address one of the questions in the Q&A, which I think is an important question, is about limitation period with regards to cases like this. So maybe Mr. Lek, you can inform us if it's a civil claim, what sort of limitation period you're looking at, if it's a medical counsel versus a criminal, because I remember a criminal case which I had following the sort of Me Too movement. A patient complained 10 years later about sexual allegation, and then it was really hard to defend without the notes and all that. But yeah, maybe you can enlighten us on that.
Yeah, so for a certain situation, potentially there can be three consequences, three different routes. Okay. The first one is patient wants to sue you for battery. That means unconsented touching. So it can actually, people can actually sue for damages, but of course it's not that fashionable here in Singapore, but possibly can. So for that, right, there is a loosely speaking a 3-year period when you want to make a claim for compensation in the courts. Okay, so there is a time period. Now, for criminal cases in Singapore, there is no limitation period. There is no limitation period. So that means basically there's no timeline within which a complaint must be made to the police for the police to investigate. Okay, so there's no timeline. For the Singapore Medical Council, okay, for the Singapore Medical Council, the recent changes to the Medical Registration Act has imposed a limitation period. Okay, sorry, just don't know why it suddenly just slipped my mind. But from since about a year or so ago, there's now a limitation period. If I'm not wrong, it's 6 years. But subject, I stand to be corrected. You can find it in the Medical Registration Act. Okay, so but of course, the limitation period for making a complaint to the Medical Council can be suspended for certain situations. Usually, it is the running of the time is suspended through lack of knowledge of the patient.
And just to the question also asked about ONG and cerebral, perhaps a child injury, birth injury claims, and that would only happen 21 plus 3 years. Is that the position in Singapore after the age of majority?
So essentially, that particular aspect is talking, if you are talking about making a compensation claim, then the principle is still, broadly speaking, the same, which is 3 years, but the 3 years is suspended for people who have what is known as a legal disability. Okay, I illustrate it very simply. Let's say a doctor, a surgeon, he operates on a patient and the patient didn't wake up. Okay, and let's say the doctor was negligent in the surgery, but the patient is unconscious. So he's under, because he doesn't have mental capacity, he's considered to be under a legal disability. So the 3 years doesn't start to run until he wakes up. If he wakes up, you understand? So he has a long time to sue you. Okay, yeah. So the 3 years doesn't start to run. Okay. So similarly for infants, underage patient, if there was negligent treatment, then and the minor wants to sue the doctor, because minority, that means you are not an adult, is considered a legal disability. The 3 years doesn't start to run until his legal disability ends. Under Singapore law, the age of majority is 21 years old, meaning that let's say you injured an adolescent, 15-year-old. What does it mean? He can sue you. Okay, he has until 3 years past 21 years old to sue you. That means the limitation period that stops him from filing a case in the court to sue you is when he is 24 years old. So there are,
thank you very much.
Depending on the situation. Yeah.
Okay. I think I've run out of time, unfortunately. I wish I had more time, but we have a lot of questions, so let's try to address them as much as possible. With that, I'm going to hand it over back to Dr. Chong for our Q&A session.
Hey, thank you very much. I think it's a very meaningful discussion. And now, yeah, that brings us to the Q&A. Just, right, give me a moment.
James, you don't mind?
Yes.
So I've answered a few, but
that's right.
But there's one that
yes.
I want to pick up on, and this is by one of your colleagues who asked, hey, I would like to have some advice on patients who are always refuse to participate in the consent taking process. So they the example that your colleague was that delegating their spouse, family member to make the decision on their behalf. For example, a 30-year-old female going for procedure, but she always say, let my husband decide on everything. Okay. So I thought this one is quite interesting. So let's have a few minutes just to discuss this. So in other words, right, if you look at just now, when I went through my presentation, what is this female patient doing? She is in fact waiving the right to information, you understand? Okay. So the law tells you, you cannot just because this patient said, no, let my husband decide, means you can just accept it at face value. The doctor should still engage her as best as he can until such time that really you are going nowhere. Then you have two choices. Okay. Number one, if you are really uncomfortable, then you invite her to go and seek treatment from another doctor very politely. You don't. Okay. I mean, if you don't feel that you want to take the risk, then you politely invite her, refer her. Just maybe you can tell her that maybe you're not comfortable with me talking to you. Then I get you someone who is might be better for you. Then you can have a chance to talk about it. All right. Or you are satisfied that there are some reasons for the lady not wanting to engage in conversation, then, okay, since she has asked you to talk to her husband, okay, then I think you can go down that path, but on the understanding that there may be some question mark if the husband were to decide on her behalf. So let's say you run through it and you talk, all the conversation with the husband, and the husband said, yes, let's go. Then you should still go back to the lady and say, before you do anything, I said, hey, I had a conversation with your husband like you told me to, and we discussed this, and she said that you would agree. So do you agree or not? Then you take it on from there. I thought this was quite a fascinating example, but James, Dr. Chong,
Yes.
what is your comment? I thought this one was quite cute.
I agree. I think in this case, the patient has, what you rightly said, has wavered, the decision to consent to another party, to the husband. I think, but as good clinical practice, I think it would be sensible for us to try to involve the patient still as much as possible in the decision-making process. And I think that also extends to when it comes to, managing decision-making with minors, for example, where legally the minor may not have decision-making capacity under the legal status, but as much as possible, we also want to seek their assent and their agreement in the treatment decision, even though the legal decision maker could be the parent or the guardian. And I think, and that sometimes is that also helps to deepen or to deepen and strengthen your patient-doctor relationship. And of course, when there could be a time where because as we know, decision making is a continuous process, consent is a continuous process, the patient-doctor relationship is a continuous process. There could be times when perhaps the patient may want to have a say or to want to make decisions for certain things, because as we know, decision making is also decision specific and time specific. So while the patient may have wavered the decision to make such a decision at this particular point in time, perhaps the condition might have changed or evolved, or there could be other information that comes in or other decisions that may need to be made, and maybe the patient may still want to make these other decisions. So I think overall, once the patient said waiver, doesn't mean that we do not talk to the patient, or we still need to involve the patient as part of good clinical care, but also involve this decision maker that the patient has appointed to be part of that conversation. I hope that answers your question that the participant have. And I think there was a similar question about the other end, which we also commonly see about family members, requesting for information not to be disclosed with the patient, such as the elderly patient, for fear of harm to the patient or for fear that the patient may not understand. This is also very common, and I think the principle was that you still owe a duty of care to the patient that you're treating. The primary duty of care is still to the elderly patient that you're treating, and I think although in the Asian context we have very unique social cultural nuances whereby a lot of times this decision making may not be just restricted to the individual itself, but that it also many times the individual is also also involved their family members, and sometimes the decision making can also be part of a group or a family or even a community. So I think in this case we need to be sensitive to the particular situation and understand the perspective of the family member to why the family member does not want the information to be shared. I think this relates to about communications and trying to understand the patient. And I think in these cases, we as doctors, we need to, of course, assert and to make our stand as to why the decision, the disclosure and the consent taking from the patient itself is still important. And to try to address the concerns that the family members may have. Sometimes it could be something that you could be simply clarified. And of course, at the end of the day, we also, as family physicians, have relationship not just with the patient, but also with the family members as well. And we want to maintain this relationship. We care for the patient, we also care for the family. Oftentimes, I find it useful is that when the family members have such a request, I'll let them know our positions as doctors, our primary duty of care, but I will be sensitive, and sometimes it could be simply, coming back to the patient, asking the patient, how much do you want to know? And how much do you know? And seeking them for their permission and their consent to the extent and the proportion that they want to be, as part of that decision-making process for that particular condition. Over.
Yeah, it is quite common in the Asia setting where family members are very much involved in the care and it's something that I constantly debate with my UK counterparts on the differences, but it's really interesting. Perhaps we can move to another question. I find this question quite interesting. If we don't have a female chaperone available and the patient we ask the patient and the patient agrees to be examined without a chaperone, is this acceptable or defendable? Mr. Lake, what are your thoughts?
I mean, actually, it is more as much to give comfort to the patient, okay, and also in a sense, so you kind of reassure the patient with the presence of a chaperone, okay. And at the same time, of course, there's also a I hate to say it, but there's also a defensive element to it, lah. So if you feel that there is a need to, then of course you should actually have a chaperone available.
Maybe I'll rephrase the question. If the patient doesn't want a chaperone, is that allowed?
I mean, yes, the short answer is yes, the patient, but
Yeah.
but actually you should
Explore, isn't it? Explore
yeah,
why
you
the
could tell the
reason
patient that no, you just say that yes, oh, it's my clinic practice and requirement, and it's also good for you, you see. I mean, but if the patient somehow is insistent for some reason or another, then you have to make a call. And of course,
and
document this down carefully.
exactly. I think the computation part is the most important because
Yeah.
a claim can happen many years later. Yeah, you're right. Chong, any questions that you want to address here?
Yeah, I think there was a question about the team-based consent in the team-based setting. I think Mr. Lik have answered. And I think generally what I feel is that if you are leading a team, then of course the team leader is still ultimately responsible. For example, a surgeon leading a team, then of course the primary surgeon himself is still primarily responsible for the consent taking for the process itself.
Actually, is the proceduralist, the one who is actually going to do the procedure. Okay, so that person stands and fall by if another doctor is actually doing it on his behalf, then the proceduralist still has to answer. If, as it turned out, the person who took the consent didn't give the full advice or the proper advice that was needed. Okay, it's still on his head.
Yeah. So I think in this case, it's important that the team leader or the procedurist ensures that the person who is taking the consent on behalf of the procedurist is competent and is able to also meet the standard of care in providing that consent process.
That's correct. That's correct.
I think the other one is about telemedicine. I think telemedicine is something that is emerging, is an important aspect of care. So I just wanted to also talk about this. I thought it was something that's important. I think in telemedicine, I think there are certain unique contexts to this. I think in general, if you look at SMC, ECEG, when we provide telemedicine, the standard of care that we're held to is no less different from that of a face-to-face consultation. So with that in mind, I think we then have to see, with regard to that particular context of that particular condition, are we able to provide sufficient disclosure and also assess the capacity of the patient, and also to assess the voluntariness of the patient in providing that consent in the telemedicine setting. And I think that if there are limitations that you are not able to do so, then you may want to talk to the patient about these limitations that you have. What are the options available? And one of the options could be that you may want to actually see the patient face to face and to do a further evaluation in order for you to give that sufficient information for the consent taking process. Mr. Lee, what do you think?
Yeah, no, I mean, I broadly I agree with you. At the same time, one also realizes with telemedicine, particularly if you are communicating through electronic medium, at the same time, it also gives you the option of providing more information. So I saw recently a very interesting case of a doctor, right? Basically, he was called in to co-manage a patient with certain conditions. So this doctor had actually not had the opportunity to meet with the patient himself, but the procedure was already arranged. He was going to be the proceduralist. So he spoke to the patient just over the phone. But at the same time, through the WhatsApp medium, he actually sent information sheets to the patient about the condition. I thought that was quite cute, you know, and it actually detailed the complications that eventually one of them eventually happened. Okay, so I said, hey, telephone call, did you actually talk enough? Yeah, we went through. And by the way, look at the WhatsApp. I sent the link to it. I said, wow. Okay, so actually, depending on the medium, there are also things that you can avail yourself of, you know. It's just
It's true, Mr. Lek.
right? Yeah.
Yeah. In
I
fact,
thought that was quite
telemedicine
funny.
oftentimes can be used to extend our reach of care. Sometimes the
Yeah.
patients, you may be able to assess the patient at times where you wouldn't be able to do so face to face and provide that added level of information, assessment, disclosure that then can strengthen the patient's autonomy and also the relationship with the patient. So that's a very good point. Yeah.
Yeah.
I
There was
think
a
telemedicine
question.
is really
Yeah.
sorry, the telemedicine is a really interesting topic, and maybe we can have a separate webinar addressing it. And me and Rob were quite fortunate to be
Yeah.
approached by the Singapore Ministry of Health regarding the latest guideline to the national telemedicine. So we did give some input to that as well, Rob. Yeah.
Actually, that's a question I thought was. It's Rob, please go ahead.
No, I was just going to agree with Uzair there. I think Singapore is probably quite advanced in the use of technology in consultation, and I think it does give rise to both great opportunities, as you were saying, James, for actually, increasing the breadth of people you can support, but it does provide some interesting challenges. So yeah, I think we'd be very interested to talk it through. And I see there's quite a few questions about chaperones as well. That sounds like almost a separate subject as well, doesn't it?
I thought there was two questions I'd like to just also seek the other panelists' views as well. I mean, that's one. I think Jane brought up a case about a legal case. If let's say while the patient is waiting to come to a decision and the patient suddenly worsens, I mean, what is the liability of the doctor in this case, and how can we navigate in such a situation? I mean, Rob, do you have any views on this?
Yeah, that is quite an interesting one. I suppose it would be quite dependent on the facts, but in general, it would be important to point out to people if a situation was deteriorating, or if people were, were increasing their risks by this, that would be quite clearly set out to them. Because in many ways, and just sort of reflecting on some of the stuff we've been talking about today, we tend to look at it when things have gone wrong and a patient makes a complaint or a claim or whatever, and then says, if I'd understood things better, I would have made a different decision, or I wouldn't have agreed to the treatment. So, I think it is making it quite clear, and I suppose having that evidence that should a decision be queried, that it's quite clear why you've given that specific patient that specific advice, and having some record to rely on.
Yeah.
And I think as part of the consenting process, if time is a factor, that needs to be explained by the doctor. What are the consequences of the delay in treatment or and so forth?
Correct. That would actually be part of the advice to the patient. That you cannot wait too long because you will get worse, or kind of thing. Yeah. And then if of course the patient said, no, I still want time to think about it, then in a sense the patient takes responsibility for the deterioration such as it is, if it should happen.
Yeah, I thought so in this case, where I think it really depends on the condition itself. So then it's also an issue of whether the doctor has assessed that in this case the condition is actually urgent. There's a risk, the urgency of the decision that needs to be made, and whether this was conveyed to the patient. And if let's say it was something that was time sensitive, whether or not that that part was actually conveyed to the patient as part of the decision-making process, so that if, let's say, that the patient does deteriorate, whether the patient was aware that, something could have happened soon and the decisions could be made sooner rather than later. But of course, I think no less coming to the need for sufficient disclosure. And I think I think it's good practice. Sometimes, patient does need time to think about a decision, and I think it will be good to discuss with the patient, okay, about interim decisions while pending the final decision, and that will also be an added level of care, and I guess of also security to both the patient and also the doctor itself, that if something were to happen in between, then at least there's a plan of care as well to address the patient's needs. Yeah. I think there was one question about mental capacity, about, trying to, if the doctor feels that the patient is about to make a bad decision, how should the doctor react in this case? I thought that comes to the Mental Capacity Act in Singapore. So I think as long as the patient has mental capacity, a patient does not lack mental capacity just because he or she has made an unwise decision. But I think it's important for us to help the patient understand the facts as far as possible, as part of our duty of care, and then to let the patient have that opportunity and space to make that judgment. And if the patient, oftentimes when we give, there could be a treatment that we think that will best benefit the patient, but the patient may actually think otherwise. I think it'll be important for us to understand the patient's perspective. And we cannot force the patient to act otherwise. But if we are assured that the patient has sufficient capacity to understand, has been given sufficient information, and volunteered to make that decision, then I think we have to respect the patient's decision.
Yeah, that's patient autonomy. It's one of your core principles, right? Of medical practice, patient autonomy.
Okay. I'm mindful of time, so we actually overrun. The questions are coming hard and fast, but we are overrun. It's about 4:15. Mindful of everybody's time. I really appreciate everybody's for your wonderful questions. I think they are very important. They highlighted many important issues in primary care. But I think it's important for us to bring this session to a close. As mentioned, reassured that we will for the questions that we not had the opportunity for the panelists to answer, we will have them answered offline, and then we will circulate it subsequently. But otherwise, I want to thank everybody, for first the panelists and also the moderator, Dr. Uzair, for bringing us through this important topic today. And that brings us to the end of today's session. We hope all of us have came away with something that we can apply every day, the 6D model, and also having a better understanding of the legal context that we operated in. Before you leave, we appreciate that if you could, when you leave the webinar, two things. One is to provide us your feedback, and two, as promised, for those of us who would like more information about signing up with MPS, this is the QR code that you can scan to find out more and to reach out to Julia. Otherwise, I have nothing further to add. Anything from Rob, Mr. Leg, James, Uzair?
No, nothing
Really
from me.
just to say,
thank you for participation. Yeah.
Okay.
Yes.
Anything from
really just to say thanks for everyone's attention. And it's been a real pleasure. And I think, as you say, some really fascinating questions coming in there, James. So be good to pick it up. And again, I suppose the purpose of this CME is to get people thinking. And if they have got questions, being able to engage with us to improve their skill set for looking after the patient. So no, it's been a really helpful way to spend a couple of hours. Thanks.
Thank you. Dr. Suraj, anything you would like to add?
No, not really. I think a very good seminar. And we will have more good sessions coming up lined up. Thank you.
Thank you. Thank you, everyone. So I shan't hold up the rest of your afternoon. Have a great weekend, and we hope to see you again at the next webinar. Thank you, everybody.